folks, the expectations are very high. People are already bought into the idea that this is the sector where we're going to see transformative changes, that AI is really already making an impact and is going to dazzle us with all of the impressive financial returns for investors, with better quality healthcare, presumably. Who wants to take the lead on this? Who's going to tell me how this is going to happen first? We can poke at it after that, but who wants to present the case for AI transforming healthcare? Naveen?
Okay.
All right.
So,
briefly.
Think about it for a second here. There is no human brain that can process the amount of complex information that's happening inside our body. So think about all the biochemical activity, all the electrical activities, all the microbial activities, and all the communication signaling that's going on.
Aren't we doing it already? Isn't that why we're alive?
Yeah, well, so the point is we don't understand it. The body is working itself, but we don't understand the underlying things of how it works. And that's the reason the more money we are spending in the healthcare, people are getting sicker and sicker. The number of chronic disease patients are going up. The fastest 3 healthcare crises are diabetes, depression, and obesity. We don't understand it. Now, only way we'll be able to understand is not only to have sensors that are able to analyze the data, but more importantly is to be able to use the artificial intelligence to be able to find the right set of patterns, both causation and correlation of what is causing what and how to modulate that things.
So this is really, it sounds like a moving forward of the old arguments about personalized medicine. I'm sure the solutions you offer are tailored to the individual.
Personalized and precision, because you can be personalized, but you've never been very precise about it.
Right.
So really the idea is, can you come up with a personalized precision way where you can prevent the disease from happening rather than having to wait until you see the symptoms. So unlike the infectious diseases, the chronic diseases don't happen overnight, they happen over time. So Parkinson's happens 15 years before, 20 years before you actually see the symptoms. Or obesity, you don't become obese one day, you don't have diabetic one day. So it takes a long time. And in the meantime, if you understand that you're on that path, you can actually stop it from happening or reverse it.
So Busy, where do you weigh in on this? Now you have a finance background, but where you are now in your perch, you look across the health system, and you're looking for ways to influence health outcomes.
Yeah.
How do you see the role of AI from where you sit?
So we don't exactly have an AI strategy. What we have is, to your point, really our job is to try to help our members manage very complex chronic conditions. For those of you who may be unfamiliar with Humana, it's one of the leading Medicare Advantage companies in the country, and so most of our members are Medicare members, obviously over 65, and as Naveen said, almost like large number of them are dealing with chronic conditions and multiple chronic conditions in many cases. And that actually is the challenge in healthcare, is that we have a system that's built for acute events that's really good about dealing with you when you break your arm, you have a heart attack, but the system is not really well set up to deal with what we always say is health that happens outside the hospital, health that happens when you're not in the doctor's office, that other 360 days. With a chronic condition, that's when it matters.
Can you give an example of how this is being applied?
Well, let me give an example of, for example, if you're dealing with someone who has congestive heart failure, you want to try to be able to get an indicator, an early indicator that they may be having some kind of a heart event. And that's not going to, they're going to be walking around, it's pretty quiet, it's a pretty silent, it's a silent thing. So what you need to do is figure out ways to get access to the data. And I want to just double down a little bit on what Naveen was saying, is that the challenge isn't that we know that there's a lot of accessible data. We actually don't have it. We don't have access to a lot of this data. There's tons of sensors out there. There is a giant, awaiting, awesome big data opportunity inside of healthcare. But the first step is to get access to the data.
What's the holdup? Is it HIPAA or something else?
I think it's both. It's HIPAA. Actually, most of the time sensors, particularly again, thinking about the Medicare population, a lot of these sensors aren't easy to use. A lot of them are hard to distribute. Where's the cord? Where'd my daughter put the cord? I can't look at it without my glasses on. Like really basic things, like making stuff very user-centric, user-friendly, to be able to get them easily and get access to data that way. Some is implantable, but some of the stuff is wearable, and you can't get access to the data unless people actually use it and wear it. The other piece, frankly, is a lot of healthcare companies aren't going to step into a lot of this data and the resulting intelligence that's going to flow from it for interventions unless they have intervention models in place to do something with the data. And so there's multiple things that have to happen in the system, not just getting access to the data. Then, yeah, AI will take off and build really great personalized care plans. But if you don't have the systems in place to intervene in that other 360 days that someone's not in the hospital to actually do the preventative work, then all that AI is for naught.
And I have seen, I mean, obviously the big trend in healthcare in the US now is a wave of mergers that are leading to greater integration. And the hope is that if it works out well, that we would have greater sharing, for example, of pharmacy data with patient care data, medical records that have typically been siloed. And an example is given of one of the insurance companies in the US already using some information on when patients with heart conditions don't pick up their medicine.
Yeah,
and
so
if it falls towards the end of the month.
I'm gonna just
yeah, tell me.
poke at that a little.
Please,
okay?
yeah.
So I think the healthcare industry has kind of rested on the fact that, particularly insurance companies, well, we have this great asset. We have claims data and clinical data, and it's really great detailed data.
What's wrong with that?
The reality is, it's old. It gets old really fast. I mean, most claims data, you don't see it until, for weeks, days, weeks, sometimes months until afterwards. Pharmacy data can be delayed, but more and more data is increasingly going to be real time. So we're going to have a high volume of data because there's going to be more and more of these sensors, and it's going to be a higher velocity. It's going to come at us real time.
Can I say what the real problem is?
What's the real problem?
The real problem is that the claims data simply tells you what you got billed for,
That's
not
right.
necessarily what you have.
I see.
And secondly, it is based on set of symptoms, not set of causes.
Right.
So that means your symptoms may be that you have diabetes, symptoms may be you name them. Remember, there is no such thing called diabetes. We name things based on certain set of symptoms. So we keep naming them so we can have an insurance code for it.
Right.
But the underlying cause is the same. 95% of all chronic diseases have one simple thing: chronic inflammation.
Right.
And the chronic inflammation happens because your body is dealing with something, a foreign object, it doesn't know what to do with it. 99% of our genes are coming from our microbes. So we'll come back and say, but the problem you have is we have waged the war against things called bacteria and viruses. 99% of our genes are being expressed by them. So we are fighting against the autoimmune disease, which is really our organ, 99% of the things. And every time you take antibiotics, you just kill 99% of your body. We are literally killing ourselves.
So there's a data problem, and there's even a conceptual problem with how we're approaching it.
I think there's
Sure.
there's two pieces of it. You're focusing on prevention, and I'm focusing on management, and those are actually two really different pieces of the healthcare puzzle where AI can play a really important role.
I'm going to skip Jay Kumar. We're going to come to him as our big thinker who's going to make us our heads explode in a second, because we also have someone who's working on treatment in a way. A neurosurgeon, Chris, you saw a problem with how we were treating patients in the surgical arena in your case, and you came up with a solution. Can you tell us about that application of AI? Because I think it's very interesting.
Sure. So my background is neurosurgery, trained in the UK, and I did med school in 2003. So working through my residency, there were a lot of cases that sort of elucidated the problem for me. I would focus really, really heavily on the surgical outcome. And there's one case in particular that I always remember because I have a picture of me in my surgical scrubs. I'm looking smug, I'm looking happy. And the reason I was looking happy was because the case had gone really well. A young lady had been hit by a car and she had blood pouring into her head, what's called an acute subdural. And it's a big operation, but relatively simple. You just have to make a big cut, remove the skull, and relieve the pressure. But time is your enemy. Time is brain. Every 1 minute, about 2 million brain cells are dying. So I was looking happy because the team had worked together to get this done in about 28 minutes. Unfortunately, later that day, that young lady ended up dying. And whenever a patient dies, you do a mortality and morbidity meeting. You look as to why, like a forensic analysis of the case. And when we did that, we realized that despite the case going really well, she'd taken 4 hours to get from the original hospital to get to the specialist operating room where neurosurgeons lived. And so I realized I was focusing on the wrong problem in this case. I was focusing on my piece in the puzzle, not the whole patient journey. So I came over to Stanford to try and solve this problem with technology, with artificial intelligence. And actually last month we got our FDA clearance for the first ever AI triage platform. And what it basically does is it plugs into every CT scanner and looks for, in this case, treatable strokes, that if they're identified quickly, you can go in, you go via the arteries and you pull the clot out. The patient will often walk out of hospital, but if you don't, they'll end up in needing long-term care, often in a nursing home. So again, it's a timing issue. But if you get taken by the ambulance to a non-specialist center, it's going to take between 3 and 5 hours to get treated. What artificial intelligence can do in this case, and it's important to know it's not just AI, it's very much applied AI. Because if the AI is working really well to identify the disease and the ambulance takes 3 hours to show up, there's no benefit to that patient. So you have to fit it into a whole system. So what that applied AI can do is present these patients to the right doctor at the right time, and we do it literally via a smartphone. I'll get an alert, I'll open it up, and the case will be there in front of my eyes. So I can get involved very early in that patient journey, rather than how I used to, which was after multiple phone calls, multiple processes had taken place.
That's fascinating, and I think we're all encouraged to know your product is getting approved to get to market. Now, Jaykumar, you, among many things that you do, you're involved with open source pharma. What are the applications you're finding for AI in drug discovery, for example?
Sure. Yeah, I'm with the Open Source Pharma Foundation, and we only have so much time left on this earth, all of us, and so we might as well do something worthwhile. And we are looking at a problem that affects billions of people, the problem of inaccessible, non-existent, and unaffordable medicine. And why does it exist? And how can AI help? So according to Tufts, it takes $2.5 billion and 10 to 15 years to make one new drug. And as a result, many diseases simply have no cure. So we're trying to revolutionize that. So open source pharma is open forms of IP, data transparency, computation, big data, and AI. And we're trying to revolutionize the process of drug discovery.
So give us an example of what you're working on.
Our first choice of disease is tuberculosis. The day after tomorrow is World TB Day. Tuberculosis kills more people than any other infectious disease in the world. And the most widely used drug is 50 years old and highly toxic. So we are using AI to do what's called in silico drug discovery. We look at massive publicly available data sets with billions of virtual molecules and tens of millions of molecules with experimental data. And we use AI to predict which of these molecules might in fact become a cure. And so there are published papers. We have an open source hut in South India where a professor volunteering his time teaches students. The hut is made out of coconut fronds. They sit there barefoot. They tap into the supercomputer system of India and model molecules and try and discover cures. And the second thing that we're doing is we're contemplating, we may actually be in clinical trials next year for tuberculosis, which would be exponentially faster, perhaps, than standard models. And that, too, because of the power of open.
That's great. That's very encouraging. I love your open source coconuts, by the way. I want to try those out. And,
they taste very good.
Yeah, apparently.
Yeah.
But you also touch on a broader question, that is questions of inequality and access, right? In a couple of other panels, we've already talked about how whether AI will reinforce the power, for example, of a handful of technology giants that have great advantage at the moment, or whether it'll be more democratic. Our breakfast session, there was a divide amongst the experts, and some argued one way, some argued the other. When we look at healthcare, let me ask everyone on the panel, what is your sense about what the role of AI and the proliferation of AI? Will it reinforce the power of incumbents of, let's say, big pharma or existing elites who have access to the best healthcare? Or is there reason to think that that the opposite might happen, that we might very well see a broadening of the base?
So I think that, this is the world of exponential technologies. The companies that are currently exist today, their data sets are useless at best because they are old and they're just not as high resolution, because exponential technology is allowing you to see the information in a way that has never been seen before. So for example, today we can take a swab of a stool and we are able to analyze every single RNA every single organism, not their DNA, but actually their RNA. What are they doing? How active they are? What metabolites they are producing? Able to look at a drop of blood, able to look at all the gene expressions of the mitochondrial gene expression, blood gene expression, to be able to see all the inflammation markers, to be able to look at the metabolites, every single small molecule of the
Naveen,
body.
that's impressive, but if I don't have $400 to give to you,
But no, it's
you're
not
not going to
one.
run the analysis.
But here's the thing. It used to cost $40,000. Today we do it for $400 for retail.
Right.
That means tomorrow it is going to be $40. So in a year, the cost of the sequencing has come down from $1,000, we do it now for $80. And I can tell you within 6 months it's going to be $15, right? So that means within the year, this thing is going to be cost, just like cell phones.
Right.
It used to be only rich and affordable.
Sure.
It became for everyone. The technology is going to be the greatest democratizer, and it demonetizes everything. And AI is just one piece of the technology. Let's not just make AI the center of the universe. AI can only do the job when you have all the right set of information.
Right.
So to me, the AI, along with the other exponential technologies, the sequencing technologies that are happening, and all other sensors that we are building that are going to be nanobots in our body. As we start to get those things, the sequencing may go away because we are now able to do the sequencing on our cell phone. So Oxford Nanopore, they're building a tiny, tiny sequencers. Someday they're going to be inside our body, and we'll be able to analyze everything on the edge. So I really believe someday you're going to be so cheap that it's going to be part of the human body.
So Naveen's clearly drunk the Kool-Aid. In fact, he's probably synthesizing it in his labs to sell to us for a declining price. I don't know how you're going to make a profit on that, but who on this stage challenges that view or has a different point of view? Jaykumar?
Well, I'm not so sanguine about AI generally. All technologies fit into a social context, into a power dynamic, and if you add AI to, let's say, a totalitarian type state where the traffic cameras are looking at who you are and where you are going and can link that to what you've spent, that becomes very scary without certain principles and safeguards in place. Having said that, technology is technology. It's a tool. It's not going to create justice or utopia. It depends on how it's used. It's on us.
And in healthcare, how do you see it specifically?
And so in healthcare, I mean, we are interested. We use machine learning. We use artificial neural networks to try to analyze some of these problems and address the diseases that to date have been economically infeasible to address. And so if we can produce a new cure more cheaply and bring it to people who have no succor right now, then that would be wonderful.
I totally agree with you. It's a tool that we're going to use to try to figure out, and I know at a place like Humana where we have a lot of members who are in rural areas who do not have access to really great health care. And in order to be able to provide that kind of health care, you might need to be able to tap into what they have in their region. And if you can create really great supportive tools for those people that are going to be able to access to information they wouldn't otherwise, recommendations, a much broader view of that, the holistic view of that member, then that person's going to get care far better than they would have otherwise. And it can be in person, it can be virtual, but all of those, increasingly, the solutions, a little bit like what the prior panel was talking about, is that people are going to be able to operate at the top of their license. I mean, we have this goal at Humana that we've stated publicly, which is that it's our mission to increase the health of the communities that we serve by 20% by 2020. It's a bold goal. We've set it and we measure it. We go out and we use CDC's Healthy Days goals, and we actually go into communities where we are and we measure, is health better in this community, and are we moving towards our goal of increasing it by 20%? So when you have that measure as a healthcare company, you're actually super focused on those people who may not have access to health care.
What does it mean to increase health outcomes by 20%? What does that mean? How are you measuring?
Well, we use the CDC's Healthy Days measure, and that means that it's a self-reported measure. So that means when you poll a certain sample size of people, you ask them how many healthy days they had this month, and the goal is to make that number. We want 20% more healthier days. We want people to be 20%, record 20% more healthier days. And I can tell you, in some areas where we're in, Humana is in the Southeast. We're in poor communities in New Orleans, and a lot of places where access to care is hard. There are places where air quality is challenging. So when you're actually having to go in and work not just on chronic diseases, but we're actually having to work on a lot of things around social determinants of health, access to food and so on, so that you're not going to move the needle. So to me, AI starts to become a really important tool to start to help those communities that have been otherwise underserved and have not had
I want to add
access to
something
care.
to
Well, but let's get a couple. Chris, let's go.
Yeah, no, I agree completely with that. And I think the theme has been, how do we increase access, which means how do we decrease the standard deviation in care? If you happen to go into, one of the best hospitals in Boston, for example, you're going to get excellent treatment. And yes, we can do things to provide extra drugs, extra treatments, but really if you want to make a big difference to the US and to the world at large, you need to bring up the average standard closer to that best. And you asked who's going to do that. Is it going to be the incumbents or is it going to be young companies? Obviously, I'm taking the bet at Viz that it's going to be companies that really solve a problem. And that problem isn't how do you throw AI at technology and do something cool. It's how do you actually get a patient to treatment better? Or in the case of chronic disease, how do you intervene early enough in that patient's life to prevent that process happening? And I think it's really companies that focus on that patient, that doctor, and the whole system around them that do the job it's being hired for that are going to win.
And I don't think it's a big company or a small company thing. I do think that big companies recognize that they're going to need to partner their way into this. They're going to need to partner with agile, fast companies that are going to be able to provide discrete use cases to be able to go out on this stuff. So I think that's going to be through partnerships.
I think the biggest change, I think, Vijay, I'm going to say is going to come from a direct to consumer. I really believe this is the time, the time is so ripe to allow each individual to become the CEO of their own health. And I really think this is going to be disintermediated. So a lot of the times we rely on the hospitals, the doctors, and the primary care physicians. I really believe they're going to be disintermediated because you as an individual is going to not only know what's happening inside your body better than a doctor will ever know, but more importantly, you will have direct action what you can do. And what if the food was the only medicine you needed? What if you go back to the let food be thy medicine, let thy medicine be the food? What if you could know exactly what food you need to eat, what nutrition your body needs, and that prevents from diseases from spreading and reversing? And I really think for first time, you're going to start to see every industry in the world has been disintermediated. Healthcare is going to be the next one. There's going to be disintermediated.
But isn't there a fallacy in that argument, this idea that if we could only empower individuals with enough knowledge, information, tools, that we would all be healthy and live to be 120 or something? There's a lot of complexity involved, and people are fickle. Some people can't be bothered to be healthy. They still make bad choices, or their lives are very busy and they don't have time. And so just giving people the information that doctors have at the moment doesn't assure outcomes.
That is only partially true. No one can force someone to be healthy. The question we never say is you can eliminate chronic illnesses, but you can say we can make chronic illness optional. That means for each person, they get to have a matter of choice. They want to be sick or not. And I think people don't want good health. What people want is a good life. Right? So if people don't care if you tell them you're going to develop cancer, they say, well, I'll deal with it when it happens. I'll cross that bridge. But if you tell them you're going to be impotent tomorrow, if you don't do that, they take care of themselves.
All right. Jacob, you wanted to get in before.
It's a small thing of, and this is my human rights lawyer background. I think when you look at a technology, you have to look at who can use it. And AI is not a cheap technology, so it'll go to the more powerful players politically and economically. And so that's the sort of context it goes into. It's not a person on the street.
It isn't cheap yet, but the curve is clearly declining in terms of cost. And so but your point is well taken. Vaccines were something for elites as well.
Yeah.
And now it's probably one of the most effective interventions to save lives, right? So we can look at that.
I'm Cheryl Reed with Dover Corporation, and I've got a question for Jacob Marr. Yeah. The Human Genome Project back in 2003 kind of set the standard for open sourcing of medical research. And it seems like big medical companies had put a halt to that really quickly because they would lose their IP if they were to move forward with open sourcing medical research. So big pharma versus open pharma. How are you managing that, and how are you dealing with the impact of big pharma on being open?
First of all, we are initially looking at neglected disease, infectious disease, diseases of the poor, which are areas that big pharma almost structurally cannot handle. There's not enough revenue. So in that sense, there's no conflict. There is also it's an interesting relationship we have. We also are sort of trying to pioneer or help pioneer, I should say, along with many other groups, an open way of doing things. And Big Pharma knows that they need to explore different ways of doing things. And as such, we collaborate. They come to our conferences, et cetera. Down the road, there's a tension, between these different types of approaches. And maybe if you look at what happened with open source software and standard software, there may be ultimately a sort of détente and symbiosis that is reached.
And I think we've seen some of the big pharma companies, for example, Novartis, when dealing with diabetes, declared some years ago that this is such a hard problem that no one company is going to be able to crack the code. And also they found they couldn't get the world's best scientists to work with them on a secretive IP-driven basis. So they decided to pursue the research in a more open basis, including publishing, before they monetized it. And I challenged the chief scientist there as to what's the logic of this. And at the time he said, first of all, we have to do it. We have no choice. We can't figure out the puzzle ourselves. But secondly, we still think that by having worked closely at the cutting edge, we can still get to market with a product faster than our competitors. So they still see some advantages in this. So it could be, as you say, that there's a frenemy relationship between the open and the closed approaches that might push the boundaries of science forward. So that's good. Great question. Thank you. Another question from the floor? If not, while you're thinking about it, I've got a question. I think, Chris, you mentioned you're from the UK. Did I hear
Yes.
right? Of course, famously, the NHS delivers most of the healthcare in the UK. What's your perspective now that obviously you're operating in the US, you've got FDA clearance, we have a hybrid system, largely private sector delivery, which is more likely to adopt AI successfully and the related tools in health delivery to improve outcomes? Something that's somewhat centralized or something that's more anarchic, decentralized, and historically has been seen to be more innovative, like the US?
Well, I think both, but in different ways. I think in the US, you have to pay attention to the financial impact of your tools. So either you need to save money or help them to drive volume to generate revenue in order to get rapid adoption across the board. In places like the NHS that we're working with, absolutely, it's going to be a central procurement process. And they're very forward-thinking with how they're thinking about AI. In most of Europe, a lot of the universities will have their own initiatives. The question is, how do you do this at scale? And are there incentives there for companies to focus on those centralized social healthcare systems versus the US? Where if you have something that the big health systems want to adopt, you're going to start generating revenue very quickly. For me, anywhere we put this improves our system. So, right now we're a young company, but towards the end of this year, we're going to be opening up a foundation to make our technology available for free in the developed world. And
Developing world, presumably.
Developing world,
Right.
Yes. And that's not wholly altruistic, right? If we put this in the developing world, we're going to learn not just about the data that we're using and improving our algorithms, but also how this is used by providers, how patients interact with it, etc. And I think that's a model that all companies should look for.
And we see a tiered pharma, after much resistance, pharma companies have embraced certain kinds of tiered pricing for HIV drugs and some others. So you see this for devices also, as is your product's a device, obviously. That this is something we move towards.
So our product is classed as a device. It's a software device, so purely software, so absolutely.
Yeah. On this question about how healthcare delivery is different in emerging markets, there's been a lot of hype around so-called the doctor in your pocket or AI smartphone. I think, Naveen, I remember a decade ago being at some X Prize brainstorming session where we were discussing this, and this is going to be the next big thing. Whatever happened? Why is there no doctor in my pocket? And in particular, the idea, of course, being if you're in a rural village where the clinic is 20 miles walk and you get there and the doctor doesn't turn up that day, the idea of having a local language expert medical advice on a smartphone or even a feature phone,
actually-
it sounds very good, right? What happens?
It's happening right now. I mean, so in
How
a sense that-
effective is it?
So effectively today, I mean, look, we launched the company called Viome, and essentially at home. So you don't have to have a hospital next to you. You can take a swab of your stool or a drop of blood, and you mail it, and boom, in your whatever the Android phone you have, you're able to get actual results of what's happening inside your body and what you can do right now without having to have a doctor. And you can have access to doctor if you need it. But the fact is the AI is constantly communicating. So it's not a science fiction. We do that today. Today you could be in the rural areas in America or anywhere else. You send the sample, we send the stuff back to you, and you see it right on your smartphone. And our AI is constantly communicating and getting a feedback, and we tell you exactly what you need to be doing, the action plan, and working with you. So the thing that you and I talked about 7 years ago, it just is now finally a reality. And we changed the name from a digital doctor to Viome.
I see. There you go. I wasn't setting him up. I didn't know that. But since you've talked up your company sufficiently, let me push you to show us. I'm sure you took your own test.
Yes.
How has it changed your life?
Of course. So interesting thing is that I'm a vegetarian, and I was actually trying to lose weight, and I was pre-diabetic. And everyone told me that's easy. You need to cut down all the carbs, start eating healthy. And eating healthy means eat spinach, eat avocado. I'm vegetarian to begin with. I'm eating lentil, legumes, tofu. Turns out the first thing I did the test, it told me the things I need to be avoiding are oats, spinach, avocado, lentil, legumes, and tofu, because that's exactly what was causing the inflammation in my body. And it says, start eating gluten. 50% of my diet needs to be complex carbohydrates. Right? So interesting thing was everything that was considered healthy was unhealthy for me. And what we realize is there is no such thing as healthy food. It is healthy for you or unhealthy for you. That means one man's food is another man's poison. There is no universal healthy food. A food that can be non-inflammatory, it could heal one person and cause inflammation in another. So knowing exactly what's happening inside your body is the key. I lost 7 pounds after I changed my diet, and I love my new diet. I'm eating bread, I'm eating wheat, and I'm loving it.
I see a diet cookbook coming up in your future.
But by the way, my wife completely different. She needs to be avoiding everything that's good for me. So the idea of having a family dinner is somehow against all the personalization and precision. So she needs to be avoiding carbs. She needs to be eating avocado and spinach.
So thank you. That's not the answer I expected. So. Basically, let me ask you, it does get a little bit to one of the challenges with AI and healthcare more broadly, that's behavioral change. We have things that we're taught are good behaviors, and sometimes we're naughty and we pig out or we drink too much or whatever. In your business, it's very much in your interest, in your company's interest, to nudge people to behave better in ways that your science shows is healthy. How can AI tools help with that? How are you working on the nudge?
Well, so it's interesting because I mean a lot of what we have to do is like day to day. It's very real. Like it's not our innovation is not like what's going to happen 5 years from now. It's like what are we actually going to be able to execute near term and test and learn. So there are a lot of small applications. When we look at AI, there's probably two spaces that it's going to have the nearest term impact. One is around the care team, the people who are actually caring for our members. And it isn't just physicians. Again, I'm going to go back to chronic condition management is a lot of stuff that happens outside of the hospital, outside of your engagement with your regular doctor. There's a lot of work that happens with nutritionists and pharmacists and diabetes coaches and stuff outside of when you're actually in the system. Those people have a massive amount of information around all those days that you're not in the hospital, and how does that get connected into your doctor? And then if there's a signal that comes from that, how do we know if somebody's feeling dizzy? What's contextual that we have around that? Did they just lose their spouse? Did they have enough money for their medication? Did they did they get out of the emergency? Did they get out of the emergency room yesterday? Like, what are all the contextual elements around that? So there's a piece around care team, and there's a piece around what we call the member experience, which is virtual assistants, which actually are going to be really very real, which is just Alexa and Google Home. Those kinds of things are going to be able to provide very personalized real-time information. Most of them are not HIPAA compliant yet, but my expectation is they will go that way. When they do, then being able to engage, in some cases with a cell phone, with texting, with chatbots, those are going to be the things that are going to start to become super hyper-personalized to help you with those nudges. And those nudges, a lot of times in the old days, I did some marketing in my life too here, but used to have all these sort of attitudinal categories that you would break out everybody, and they would just be a data decisioner or a reluctant, adopter or whatever, right? So nobody is those things 100%. Everybody is these. We are just like our biome, right? We're these like crazy, changing, dynamic beings. And so AI is going to help us stop having these one-size-fits-all, not just categories, but also dynamic, adaptive ways of engaging with us. So I don't know, how many of you guys? I'm just going to ask. How many of you have been on a diet? Yeah. How many of you have been on 2 diets? How many have been on 3 diets, okay? So just recognizing the fact that just because you have done something once and been successful, you're gonna find that, it's a little different for me 3 years later.
Right.
Because it's just, my world is different, my head is different, my space is different. So these kinds of tools are gonna be the things that are gonna allow us to create dynamic interactions with our members.
So that's fascinating. So it's not just a one-time, one-shot tailored approach for me as a personalized.
It's like real
it's
time.
ongoing,
It's like real time
really deep understanding of my
What's up with you
behaviors,
right
what time
now,
of day,
what's happening.
and over time
Yes.
we change. So that's the world we're moving towards.
That's
and
right.
That's impossible to conceive without machine learning, without AI
Exactly.
being done in the right way. I mean, we're some ways off from that, obviously. But that's useful to get the vision. With the time remaining, I want to take on a topic that we haven't talked too deeply about, and that is the relationship between AI and doctors. And we have a doctor on the panel, so perhaps I'll direct it to you. Doctors are seen historically as gods, as all-knowing, at least from the perspective of the patient, before the age of empowerment and so on. And with tremendous power, a lot of knowledge, but also lots of studies have shown that, for example, doctors in the US very often don't follow what is known and shown through clinical trials in the published literature to be the best dosing or medication or practice for a certain kind of care. They deviate from that, sometimes because they think they know better, or they think their own life's experience is more revealing, or they didn't read the article in JAMA, or whatever other reason. So can you answer to us the arrogance of the doctor? What can, especially as a surgeon, you've heard this question before.
Not just a surgeon, he's like a brain surgeon.
Exactly.
Woo!
Although you are very humbly presented here today, so we appreciate that. I don't know about the socks, though. But, can AI, there's a lot of talk about AI assistant or something to be a nudge or a guide for the doctors, the physicians, to review the tens of thousands of articles that you have to keep on top of and recommend what you should do. What's the attitude of the physician towards these kinds of nudges?
Yeah, I think pretty much universally, doctors want to help patients and do the best for the patient in front of them. And when they're not following a guideline, it's because they have extra information or they think a certain way. It might be because they don't know the guideline yet. They haven't read that paper. You're absolutely right with that. And so what the role of AI is, in my view, again, is to reduce that standard deviation, that access not just to care, but to information about that particular patient. And I would love to see a system that was able to identify generally what was going on and provide that information to the doctor at the right time, whether that's the latest JAMA article or it's the new drug dosing that the AHA have come out with. And when doctors see that and it applies to that patient, they're going to follow it. I think...
I mean, there are apps that try to do this already that are popular with doctors, but what I've observed and read is that doctors don't always follow that advice.
Well, the problem is we don't like it when technology is just thrown at us because, as you just said, Busy, like, healthcare is complicated, patients are complicated, so it's not one size fits all. So we have to take into account the context of that patient. Will they actually take this medication? Are they actually going to come back to me? Do they even have a place to live? All of these things determine what kind of treatment this patient might need. For example, let's say it's after an operation, the guidelines say I should leave a drain in for 3 days, but that patient's homeless. Am I going to send the patient home with a drain that could cause an infection? No, I'm not, so I'm going to avoid the guidelines. So really what you need to do is surface the information and respect the fact that doctors have spent their whole lives learning and doing their own machine learning about patients, combining cognitive information with associative learning of, hey, if I treat a certain way, this patient might do better. But we need to aid them in that journey.
Great. I think that's actually a poetic note to end on. As we've heard consistently throughout the day, and I think in greater nuance and detail with this panel, the technologies are remarkable and advancing. We can see the applications and even some tangible ones already, but this is really something that's likely to augment, improve, and enhance existing roles like those of doctors, and maybe create some new ones, like the patient that takes care of herself or himself, and therefore maybe making progress on preventive care and so on.